everyone doing? I feel like before I start talking, I have to make like a generic comment, like back when I went to med school here, I was in this classroom.
Yeah, nice.
So I think I know most of you guys. My name is Musa, and I'll be giving my second WIP talk today. The title is Abnormal Kinematics in the ACL B as a mechanism of early onset osteoarthritis. So I'll just get started. So here's a quick outline of my talk. So I'm going to give a brief project overview, even though my last WIP was only like a week or two ago. I'm sure many of you guys forgot what I'm doing. I'm going to go over a short sort of preliminary data set of patients that we have and look at some correlations between knee kinematic measurements as well as cartilage damage and knee kinematic measurement and patient-reported outcomes at 1 year. I'll talk about future directions as well. I'll be doing with the rest of my year. So a brief sort of overview. So in my project, I'm basically looking at the ACL, and it's basically the primary stabilizing ligament in the knee for anterior posterior stability as well as rotational stability. And we know that basically following ACL injury, 50% of patients get radiological evidence of osteoarthritis 10 to 15 years later. And ACL injuries are very common, close to 1 in 3,000. So you can see how this is going to be a big problem. Additionally, papers have shown that knee kinematics are known to be altered following ACL injury and ACL reconstruction, although there are no sort of longitudinal studies that show the correlation between knee kinematics and cartilage damage. So that's where my project comes in. So for my project, it's a longitudinal cohort study, and the goal is to investigate the longitudinal interrelationship between cartilage degeneration and knee kinematics following ACL injury and ACL reconstruction. And we hypothesized that changes in knee kinematics following ACL injury and ACL reconstruction are correlated to the faster progression of cartilage degeneration, as well as lower patient-reported outcomes at 6 months and 1 year post-reconstruction. So for my project, we're looking at 50 patients. We're following them prospectively, sort of at a baseline measurement that at 6 months and 1 year post-reconstruction. At each of the time points, we get two types of MRIs, one that looks at knee kinematics, so the way the knee moves, and one that looks at knee cartilage. We also get patient-reported outcome surveys at each time point as well, so before they have their reconstruction at 6 months and 1 year. And we also get sort of performance testing in which we look at the way that they walk and get 3D motion analysis as well. So for the statistics of my test, I'm using two main tests. I'm using a paired student t-test to look at similar measurements. So if I want to compare kinematic measurements at baseline before reconstruction and at 6 months and 1 year, that's what I use that for. And then I'm using a spearmint rank correlation coefficient to look at correlations between things that are not related. We want to see if they are related. So between kinematic measurements and cartilage damage, or kinematic measurements and patient-reported outcomes. And these are the values that I'm using for significance. So a brief overview on my workflow. So this is a schematic representation of a patient laying down inside an MRI machine. We scan the patient in both the extended and the flex state. So we get two types of MRI, as I mentioned. We get a T2 MRI, which we go through and we segment the bones out, and we get a 3D reconstruction, and we get kinematic measurements. And then we get a T1 row MRI, which looks at the cartilage, and we get all our cartilage measurements from this. So the kinematic MRI is important because this is where we get our kinematic measurements. Specifically, we're looking at anterior tibial translation. So we're looking at the distance, we're basically looking at the distance that the tibia moves in relationship to the femur from the extended state to the flex state. Our T1 row MRI is really good at quantifying biochemical changes in the cartilage. So we have T1 row MRI, we look at the different cartilage compartments in the knee. We look at the medial side and the lateral side. The medial side is of more clinical significance because we know arthritis is more likely to occur on the medial side of the knee first and then the lateral side. And the take-home message of the T1 row is that if a patient has higher T1 row values in their cartilage, that's associated with worse sort of cartilage damage. So it's worse to have higher T1 row. And as I mentioned earlier, we also get patient-reported outcome surveys at each time point. And the main survey that we're looking at is called the COOS survey. It's a knee injury and osteoarthritis outcome survey. And this is a really well-validated knee survey that's used in a lot of orthopedic and physical therapy studies. It has 5 main subscales of pain, symptoms, activity of daily living related to your knees, sports, and quality of life related to your knee as well. So a score out of 100 is a perfect WHO score, and that's what we kind of aim for. And a score of 0 is basically really bad, like you don't have any knees, essentially. So for this preliminary analysis that I'll be talking about today, we looked at 12 patients, and then, since this is a prospective cohort study where we're following it, basically forward on, this is the number of patients who we have data for at 1 year, 6 months, and baseline. A year or two from now, we're going to have sort of a larger number of this, but this is what we have right now. These patients all have MRIs at all time points as well as survey data. And some brief demographics on this population. The average age was 33.7 years old. The average BMI was 23. There were 7 females and 5 males. So this first set of data I'm going to show is just basically looking at kinematic data, specifically looking at anterior tibial translation in the injured knee versus the uninjured knee at the different time points. So in this first graph, we have 3 different time points. We have our baseline, so this is prior to ACL reconstruction, then we have 6 months post-ACL reconstruction, and then at 1 year post-ACL reconstruction. We have 2 lines at each time point. So the sort of reddish line represents the average anterior tibial translation in their injured or their reconstructed knee, and the blue line represents the average ATT in their non-injured knee. I know you guys are staring at this, and you're kind of probably baffled because at this point right here, this is where these patients have a non-functioning ACL. So this is before ACL reconstruction, so they have a torn ACL. And you're probably thinking that if someone has a torn ACL, they should have more anterior tibial translation compared to the knee that doesn't have a torn ACL. And that was our thinking too when we saw this, and we were kind of surprised and a little bit baffled by this. So we've been trying to kind of think of reasons as to why we're seeing this. And one reason that we're thinking is that patients may not be fully relaxed when we're scanning them baseline. We might be a little bit hesitant with this torn ACL, and we may not be seeing the full anterior tibial translation at this point. So then we fast forward to 6 months, and I know what you guys are thinking again. You're like, so these people have had an ACL reconstruction, and now all of a sudden they have more laxity in their knee compared to when they didn't have a reconstruction. That's what we were thinking too. We're also a little bit concerned. So we did a quick sort of search in the literature, and what we found was that graft incorporation doesn't really take place until about 11 or 12 months. So, we might go in, we might put in, a hamstring graft in the own patient or, some sort of cadaveric graft, and it might have a little bit of play and stretch in it. Then over the course of 6 months to 1 year, it might become scarred in and kind of fibrosed, and it gets a little bit stiffer. So, that might explain this finding from 6 months to 1 year where it kind of normalizes. But I do understand if you guys were like, this doesn't make any sense. These graphs right here just shows the side-to-side difference in the average anterior tibial translation. So this is just the anterior tibial translation in the injured side minus the uninjured side. It's the average for these patients. So from baseline to 6 months, there's a borderline statistically significant increase in ATT. And from 6 months to 1 year, there's a significant decrease in ATT, sort of back to normal, sort of the baseline value of this. I'm sorry, one thing I want to point back out on this graph is that, another possible concern is, are we acquiring these images right? Are we segmenting them right? And is our data right? And I think something that is positive on these graphs is that their contralateral side stays kind of constant at all time points. So that's a good sign. If we saw large variations in the knee that, was not injured, that'd be concerning. But I think the fact that it stays kind of constant helps sort of justify what we're seeing here. So this next set of graphs we're going to look at is the basically kinematic data, sort of anterior tibial translation correlated with the T1 row value, specifically looking at the cartilage damage. So this first graph right here shows the relationship between anterior tibial translation at 1 year in the injured knee or the reconstructed knee at this time point with cartilage T1 row values in the medial, femoral, condyle cartilage. And as you can see, as you get more anterior tibial translation, you also have an increase in your T1 row value. So this is showing strong correlation between our kinematic measurements, or anterior tibial translation, with our cartilage T1 row, our cartilage damage. This has a pretty strong correlation of 0.83 with a pretty low p-value. We also see a similar finding in the lateral femoral condyle as well. So this is like pretty exciting for us. This is like our first sort of correlation between the kinematics and cartilage damage. So this graph right here shows our anterior tibial translation at 6 months and how it can predict the change, the T1 row value from 1 year to 6 months. So on the y-axis right here, we have a change in T1 row from 1 year to 6 months. So we took the T1 row value at 1 year, subtracted from the 6 month value T1 row. So we want to see whether or not it's actually going down, increasing, or staying the same. and this is looking at the anterior tibial translation at 6 months. So as you can see, the ATT at 6 months is predictive of the increase in the cartilage T1 row from 6 months to 1 year. So this is kind of exciting. Yeah.
I'm curious, are you going to look at the T1 row of the contralateral knee as well, just to make sure that these patients don't have damage at baseline?
So absolutely, I don't have any of that data in here. That is something that we are kind of looking at. So the question is, I think a main question is what is sort of a normalized T1 row value, and that is something that we definitely want to look at. But we also have to be kind of concerned about if these patients who still have one good knee, if they're changing the way that they're walking, they might be putting more force on their, basically on that good side. Does that change their T1 row value? So, I think something that we still have to go back and do is look at the average T1 row values in all of our control patients who have not had any sort of ACL injury of knee surgery either. And this is that same sort of finding that we see in the lateral side of the knee. So it's the same sort of, it's basically a correlation of the ATT at 6 months with the change in T1 row from 1 year to 6 months in the lateral side. So this next set of graphs right here is going to be our kinematic data correlated with our patient-reported outcomes, so our anterior tibial translation and how that correlates with our KOOS data that we have. So this first graph right here, on the x-axis we have our ATT value, which is basically the kinematic measurement, and how it relates to our KOOS symptom score. So this is just 1 to 5 subset. So as you can see, as you have more anterior tibial translation, you have a decrease in your KOOS score, and if you have a lower KOOS score, that's bad. And this is statistically significant. And in fact, we see the same sort of relationship in 4 out of the 5 KOOS scores. So we see a decreased KOOS score when you have an increased anterior tibial translation for the KOOS symptoms, the KOOS pain, the knee activity daily living, and the knee sports score. Surprisingly, they don't really have any significant decrease in their knee quality of life score. So the knee quality of life questions are like, do you ever notice the problems with your knee? Do you not feel confident on your knee? So it's obviously not like, it's not really bothering them too much, but they are sort of still basically having some pain and some symptoms with these. This is kind of exciting for us because this was the first correlation that we made between the kinematic measurements and the patient-reported outcomes. And this basically shows how the kinematic measurements at 6 months can be basically predictive of their outcomes at 1 year. So if we can scan a patient at 6 months and they have a lot of ATT, we can probably tell them that at 1 year you may still have a lot of pain and you may not be able to run and cut, but your quality of life is probably going to be okay still. And the good thing is that we do see a longitudinal improvement in the KOOS score over time. So these are the 5 subset of within the KOOS. So we have the symptoms, pain, activity of living, sports, quality of life, and each color represents a different time point. So the blue is their average baseline score, the red is their average 6-month score, and the green is their average 1 year score. So as you can see from baseline up to 1 year across all 5 sub-scores, we have a statistically significant increase in their KOOS score. So that's always good to see. They're not going down, they're not staying the same, they're all getting better. So we can always tell patients that at 6 months you might still be having these symptoms, but at 1 year we actually expect you to get better. So some brief conclusions. So changes in knee kinematics in the axial reconstructed knee are correlated to these technical cartilage changes. Specifically, anterior tibial translation at 1 year leads to increased cartilage T1 row values in the medial and lateral compartments of the knee. Additionally, changes in knee kinematics at 6 months are predictive of cartilage changes at 1 year. So this is looking at the anterior tibial translation at 6 months and how that can predict increased cartilage T1 row at 1 year. We also see that changes in knee kinematics in the axial reconstructed knee correlate with worse patient outcomes at 1 year. So we saw how the anterior tibial translation at 6 months can predict worse patient outcomes with 4 out of 5 KOOS sub-score at 1 year. And the good thing is that we see a longitudinal improvement in the patient-reported outcomes from baseline before surgery up to 1 year after the habit of reconstruction. So as far as current progress is going right now, so as I mentioned, this is a prospective cohort, so we have patients constantly coming back. We're basically pretty much close to our fulfillment in our baseline number of scans. So this shows that we have 49 usable scans. In actuality, we recruited close to 54 patients so far, and we're probably going to stop enrolling patients pretty soon. And now patients are coming back for their 6 months and 1 year scan So the bulk of my time throughout the day is basically spent on data, it's a mix of data acquisition and data data segmentation. So it takes a long time to go through each MRI and each slice and cut out the tibia bone, cut out the femur bone, other parts, and make a 3D reconstruction. So these numbers are looking pretty good right now for me, but they're probably going to go up as patients start to come back for their follow-up. I've also been sort of lucky to actually submit a few abstracts so far as well, which has been nice. So as far as future direction goes, the big part is going to be to continue with all the data acquisition and the data processing. It's going to be a big chunk of time for that. I think it also makes interesting to kind of look at the correlations between the cartilage and patient-reported outcomes to see if patients who have higher cartilage T1 row values, if that at all correlates to sort of lower pain scores and lower symptom scores in the KOO score. And so basically, if people have more cartilage damage, are they having more pain, or is this something that we're just seeing on an MRI that might not be clinically relevant at that time point? We also have a large database of functional testing that we get at each time point. So we do a lot of gait analysis. We do a lot of 3D motion analysis and force testing at each of these visits, and that's something that we've not really looked at yet. So that's something that I definitely want to explore and do some background reading on. So of course, I want to thank the Clinical Translational Research Fellowship, Dr. Ma, who's been a great source of support for me, Dr. Shajan and me, Dr. Drew Lansdale, and Dr. Brian Lau have all been very supportive of my project.
This group is quiet today. Yeah. Everyone always has questions.
Concerns? There's all thinking about a long publication lecture. They're not going to get published.
Musa, seen, you showed the average scores of patients increasing over time, but I was curious about outliers. What about the patients who don't, or on the average, are they increase more than? Have you thought about looking at those? I'm just curious.
Yeah, I think it's always good to look at outliers. That's not something I would look at. So I think it'd be really fun to see if the patients who have really low KOO score. So if someone who's got a symptom score of 30 or 40, to see if that patient has a lot higher ATT value. If someone who's got a really low KOOS pain, have a low KOOS pain score at 1 year, if they have a high T1 row value at 1 year. That's not something that we've done yet, but I think it's a really good point. I think people are always kind of tempted to throw out outliers, but I think it's always good to kind of look at them because they might be a different sort of subset that can give you basically a better answer that you're looking for.
And I'm just thinking about the patient in front of you and how you're going to counsel them on how they're going to do over time based on their particular baseline.
Absolutely.
Yeah. Any other questions?
Though you were curveball, since you're a fellow student of some nice. What's a potential pitfall? There's a longitudinal cohort with these studies. Now you try to make correlations. So anytime when you have these cohort studies, to try to look at correlations, what the potential pitfalls?
There can always be a lot of confounding factors in these. So we're not asking these basically patients about sort of the other things that are going on in their lives and stuff. We're not looking at their knee. We don't really ask them if they've had sort of any sort of other injuries at this time point. So I think if you're not doing sort of like a multivariate analysis, you can definitely run into problems with that. That's not something that we really thought about with this. Additionally, I think something that is another problem with this possible study is our data acquisition has always been sort of an issue with this. We have a lot of different people doing MRIs, a few different people doing all the segmentation, and it's been sort of a possible source for us to introduce some error and stuff. So the way I segment the bones out might be different from the way someone else does, so we might be getting different measurements at different time points. So I think it's always good to be sort of cognizant of that and looking to see, so if 1 year all of a sudden this patient has a really high ATT value, and then at 6 months it was really low, it's probably good to go back and look at that. But I think in relation to the KOO score, I would probably say confounding factors.
So I think those are all important things, like quality check, the QA is important, and when we talk to people doing the same data set, it's nice to kind of produce, try to look at it, try to observe it, analyze it from there. And then I think that the afterwards when you guys look at correlation, you need outliers. You need outliers to look at what your curves are. If all my patients surgery do great, we can't have one of the potential pitfalls for these larger studies, and hey, what if everybody does well? Or what if everybody doesn't develop arthritis? Then, then you can't prove your hypothesis. So you need to have some people on to it, so that you can kind of show out to see, hey, where that curve. If everybody does well, then you can't call it. Set it down.
Lisa, did you have a question?
Yeah, I was kind of going along with that. You had other indicators that you were looking at in addition to what this assessment had.
Yeah, so the good thing about the study that we're doing is that there's there's like a bunch of different data points that are collected. So we have the patient sex, the patient PMI, we have another survey that we can look at. We have the time to injury from when they first got injured to when we first scanned them to when they were reconstructed. So there's a lot of different variables that we can definitely look at. But I think we've been at the point where we've been doing a lot of bone segmentation and stuff, and now we're sort of at the point where we're kind of caught up. We can start looking at these and kind of think of good sort of analysis. At the same time, I think you have to be very careful that you don't run a bunch of random correlations, that you can find relationships that may or may not be there. So it's always tempting to have a giant spreadsheet set up, just run a Pearson's correlation on everything. Like, oh, this is significant, this is. But I think that can be very dangerous. And we definitely kind of talked about that in lab and stuff. So like the rule is like, if you're thinking about something, definitely run it by someone before you run that correlation. Because it actually make clinical sense. Like I'm not going to try to see if these people tore their ACL on a rainy day and if that's related to their KU score in 1 year. Because then you might find something and then you're like, well, oh, you're not right, but the numbers say it is. So, yeah.
What's your age range?
So the age range in general for the project, I think our youngest person is 17, and then we've seen people in their 40s there. The average age so far of this was 33, I think, for this cohort that I looked at. And, the most active people that we have that do want to kind of come back for this are a lot of young active people who basically tear their ACL. So this is a problem that does affect a lot of young people. So I'm looking towards, but yeah, 33 more years.
Just thinking, a lot of studies will choose sort of more at-risk population for the outcome.
True.
So that they have a higher chance of finding something. I didn't know if you thought about that in terms of choosing like an older age group, looking for like.
Yeah. So, I think Dr. Mock definitely chime in there if I'm wrong, but we know that when people tear their ACLs, they tend to get, they basically get signs of arthritis a lot earlier on, anywhere from 10 to 15 years. So if a person is 20 and they tear their ACL, they might have signs of arthritis when they're 30 or 35. And if someone is 40, I think it's still pretty much close that age. I think it's still within 10 or 15 years. It might be a little bit basically shorter, right? But I think it's still going to take a long time for us to see. Another problem with, if we're picking out people that are 65, then, those people might just have age-related joint disease that, is not because they're this ACL injury. I think the biggest sort of market for this is the young people like me and you who tear their ACL when they're 20. That really sucks if you get arthritis when you're 30 or 40 and you're looking at getting a knee replacement when you're 50. So, it would be fun to follow these people out for 10 or 15 years and see what percentage actually get true clinical arthritis. But, I think the T1 row for now is a good sort of measure because we can see it pretty early on. And it's been sort of shown in the literature as a good predictor of arthritis later on.
That's a good question, though. We actually had a nice talk today the best age to tear ACL is when you're in your 40s. Yeah, so I'm the best person to tear ACL because I'm old enough that, hey, it doesn't matter whether ACL works or not, I'm still pretty good. The worst age to tear ACL are the teenagers in the high school students because they have such a long time to get a knee. And the small changes you see on TV, for me, probably not make a big difference. If I need a knee replacement 20 years, so be it. But if there's something that you know at 16 that you have changed early on, by the time they're in their 30s, bad arthritis, that is a problem. And we actually do see it because ACL used to be an injury that you have, never go back to school. So you would say, okay, I'm done, I'm just going to be comfortable, okay. Now, you do an ACL injury, we are so good at okay, go back to activity, you continue to use a knee, continue to be abusive with the knee, and then they actually develop like the young patients. Now we talk about practice right now, we see like 30 years old, 40 years old with bad arthritis, and they're too young. So one thing that's good is getting old. This one injury that getting old is good.
Yeah.
was just thinking of getting more reckless.
Give it up, okay?
We'll do it together.
Maybe you could.
I just had a quick question. Maybe you mentioned this last time. Did these patients have any incentive to participate in the study, like are they paid or?
Yeah, so they're actually paid a very small amount. So, we are really thankful to our patients because, they come back at 3 different time points, but each MRI itself takes about 2 hours, and then they have the functional testing, which can take another 2 hours after that. The good thing is they get paid like $100-something after like their second or third MRI, but they get 3 free MRIs, which is always nice, and then they get to go back to Dr. Mom, look over their MRIs. They get a T1 ROMAT, which is basically unique. They don't really do those yet clinically for the most part. This is sort of kind of fun for them, and they get sort of a lot of functional testing, and they get all the results from that. I think we have a cohort of patients that's actually really interested in this type of stuff. It's a lot of young athletes who really like this type of stuff, and they, a lot of them come back and they're like, no, man, thank you. This is like super awesome and fun and stuff. So, but it's like a very small incentive. I mean, for these people that have full-time jobs, like they're actually losing money probably by not going to work for that full half day. But still, it's so the long-term goal of this project is actually have a 3-year follow-up. So we'll see how that goes and stuff. But I think for the 1-year follow-up, we should have a good number of patients.